So, after having a nice introduction for which I'm very thankful, I'm starting my talk, the less common forms of BPPV. This is my first slide. I have no conflicts of interest. The outline of my talk is as under. The vertical canal BPPV subtypes, excitatory and inhibitory viewer pathways. This is important for localization and lateralization, on which depends the treatment with repositioning maneuvers and physical therapy. Case 1, apogeotropic posterior canal BPPV with positional downbeat nystagmus. Case 2, apogeotropic posterior semicircular canal BPPV with direction reversing positional nystagmus. Then I will discuss something about the diagnostic evaluation of posterior pupillolithiasis without and with short-arm posterior semicircular canalolithiasis, sitting of vertigo, and then I will take cases 3 to 7 depending on the time. So one blanket form of treatment for all variants of vertical canal BPPV, as Dr. Surjit said, is Applet maneuver. And Applet maneuver is basically technically a backward somersault. So if there are, say, 100 patients in this, at least 70% will get cured, whether on the left side, because around 50 to 70% of the BPPV is posterior canal BPPV. Now coming to the each variant, at least 6 variants I know about the posterior semicircular canal BPPV. The first variant is the typical variant, posterior long ampullary arm semicircular canalolithiasis. We are not going to discuss about this. The second is posterior non-ampullary arm semicircular canalolithiasis, one with downbeat nystagmus, that is called the apogeotropic variant. The third is posterior semicircular pupillolithiasis, that is the graviceptive heavy cupula. The fourth is the short-arm posterior semicircular canalolithiasis, the term which was introduced by Bela Bucchi in 2011, and lately it has been elaborated by Darius Coco in 2019 and 2022. Periampullary canal side posterior semicircular canalolithiasis with partial canal jam, and the sixth variant is the combined posterior long ampullary arm semicircular canalolithiasis with co-occurring posterior pupillolithiasis. So coming to this diagram, again, this is an important thing. The short-term posterior semicircular canalolithiasis and the graviceptive heavy cupula, they are closed entities, and there is another entity called periampullary canalolithiasis with canal jam of posterior canal. These 3 entities, they often co-occur together, especially the first 2 and they lead to sitting of vertigo. So the excitatory and inhibitory VOR pathways, the upper row shows the excitatory pathways of anterior, posterior and horizontal semicircular canals from the right ear, and the inferior row shows the anterior, posterior and horizontal inhibitory pathways. It's important to note that if we reverse this diagram like this, the left-sided anterior semicircular canal excitatory pathways and the inhibitory pathways of the posterior semicircular canal from the right side are to the same pair of the muscles, that is the right inferior oblique and left superior rectus. So this is an important bearing because it is often difficult to distinguish between a left-sided anterior semicircular canal BPPV, say, from the right-sided apogeotropic posterior semicircular canal BPPV. So I have made a simplified diagram of the right-sided canals. This is the right posterior semicircular canal. The excitatory projections are to the right superior oblique and left inferior rectus, causing a slow phase VOR, which is downbeating and left torsional. The positional nystagmus, which is a reflexive saccade or a fast phase VOR, is therefore upbeating and right torsional. So likewise, it applies for every canal. The inhibitory projections of the right anterior semicircular canal are to the right inferior rectus and left superior oblique, causing a slow phase VOR, which is downbeating and right torsional. So if this variant is to occur, it would have a positional nystagmus which would be upbeating and left torsional, but such thing doesn't occur. That is the canalolithiasis in the ampullary, non-ampullary arm of the anterior canal. It doesn't occur, so I am removing it from here. So this is about the horizontal semicircular canal, which I am not going to discuss. And one important point is that the slow phase VOR is the vestibular component, and the positional nystagmus, which you clinically see to lateralize and localize the canal, is a reflexive saccade caused by frontal eye field and superior colliculus. This is again to revise that the excitatory projections are ampulofugal pupillar deflection in vertical canals and ampulopetal pupillar deflection in the horizontal canals. And the inhibitory is the ampulopetal pupillar deflection in the vertical canals and ampulofugal pupillar deflection in the horizontal canals. This is a diagram. This is a slide which is important. If you replace it with the left R with the L, it will be for the left side. And you should, every young aspirant trying to establish in neurotology should have this in his consultation chamber. So with this, we come to our first case. This is a man around 38-year-old, came with the positionally triggered spells. The left dixal pike test shows a downbeating left torsional nystagmus. You can see that this is not a classical crescendo decrescendo nystagmus. This is a slow decrescendo crescendo decrescendo nystagmus, downbeating and left torsional. So the direction of torsion in the apogeotropic is towards the healthy side. So this is a case of the right-sided apogeotropic posterior semicircular canal BPPV treated with QLR, demisemon and FPP. And next day I did a straight head hanging test and it shows a upbeating right torsional nystagmus. So there was a intracannular switch from the non-ampullary arm to the ampullary arm, and this was then successfully treated with Applet maneuver. So this is my first case. So again, here I repeat, this patient could have been left anterior semicircular canal BPPV or right posterior semicircular canal apogeotropic variant, because the inhibitory projections of the right posterior semicircular canal and the excitatory projections of the left anterior semicircular canal are to the same pair, that is the right inferior oblique and left superior rectus, causing a slow phase VOR, which is upbeating and right torsional in either case. The positional nystagmus, which is a fast phase VOR or a reflexive saccade, is therefore downbeating and left torsional, whether it is apogeotropic right posterior semicircular canal BPPV or a left anterior semicircular canal BPPV. Because apogeotropic posterior semicircular canal BPPV is 6 times more common compared to anterior semicircular canal BPPV, as per the Califano in the data he published in 2021. I usually treat peripheral positional downbeating nystagmus as apogeotropic posterior semicircular canal BPPV more often than anterior semicircular canal BPPV. This is a case 2. Again, a man around 40 years old came with the history of positionally triggered disease spells. The left dixal pike test elicits a downbeating left torsional nystagmus. There you can see again slow crescendo decrescendo, not typical of the typical. On the right side, it shows a upbeating crescendo decrescendo nystagmus on the right dixal pike test for around 10 to 15 seconds. Then there is a pause. Here is the pause. And now it started changing polarity. Both the vertical and torsional components have reversed. It has become downbeating and left torsional, exactly the like we saw during the left dixal pike test. So how this happened? The otoconia were probably in the non-ampullary arm with a partial canal jam. The partial canal jam means that the portion of the canal is either atretic, narrow, or there is a large otoconial clot. So when we did the left dixal pike test, in the section B you see, there was a ampulopetal movement of the otoconia causing a stimulatory downbeat nystagmus with left torsion. As the patient was taken to the upright sitting position after the dixal pike test on the left side, you can see here, the otoconia reached the periampullary portion. And as the patient was again taken for the right dixal pike test, this happened, which I have shown here. First, there is a ampulofugal deflection causing upbeating right torsional nystagmus of the typical posterior canal BPPV. Because of the canal jam, the otoconal clot ricocheted back and resulted in inhibitory downbeat nystagmus during the Dix-Hallpike test in the later part, which was downbeating and left torsional. That is the inhibitory nystagmus. So this is in fact a apogeotropic variant of the posterior canal BPPV of the right side, which the direction reversing nystagmus. So let's discuss some important clinical pearls before talking more about the less common forms of the vertical canal BPPV. So the Dix-Hallpike test in the posterior cupulolithiasis is not the gold standard because a canal angulated cupula during the Dix-Hallpike test results in inhibitory ampuloputal deflection, generating downbeating contratorsional nystagmus of prolonged duration. A neutral posterior cupula, the plane of which is in line with the Earth's vertical during the Dix-Hallpike testing, does not stimulate the cupula and no positional nystagmus may be elicited. A vestibulum angulated cupula during the Dix-Hallpike test results in excitatory ampulofugal deflection, generating upbeating ipsitorsional nystagmus of more than a minute duration. So the gold standard to evaluate the posterior semicircular cupulolithiasis is the half-Hallpike test, which elicits a prolonged upbeating ipsitorsional nystagmus. So this is the left Dix-Hallpike position in which from the upright sitting, the patient's head is positioned around 120 degree at the free end of the examination table. However, in the half-Hallpike test, from the upright sitting, the head is positioned around 60 degrees. And if you keep a pillow of around 4-inch thickness at the head end of the examination table, like this here, you need not have to support with the hands. And this is the practice which I follow to do a half-Hallpike test. Whenever you find a prolonged upbeating ipsitorsional nystagmus of more than a minute duration in the half-Hallpike test, you have to do a inversion test. This is the half-Hallpike test position represented in this diagram. And if you get a upbeating ipsitorsional right torsional nystagmus of more than a minute, you have to do a inversion test, that is the nose down to the left. When the right torsional upbeating nystagmus in the right half-Hallpike position becomes left torsional and downbeating in the nose down to the left, it is an acid test for adherent type of cupulolithiasis. Why this is important, that we will see in one of the cases. The negative inversion test means when the right torsional upbeating nystagmus in right half-Hallpike position disappears in nose down to the left. This is, I say, non-adherent type of cupulolithiasis, which is in the inverted commas. Why it is in the inverted commas, I will tell you later. It is a dynamic heavy cupula because of the particles on the utricular side of the posterior cupula in the short arm. This is a landmark paper by the legendary Professor John Epley of year 2001. What did he say? Identification of nystagmus reversion with head inversion confirms the presence of cupulolithiasis. If persistent nystagmus maximizes in one provocative position but does not occur in the inverse position, it suggests that the cupulolithiasis may be present due to a non-adherent particles falling away from the cupula in one of the positions. But in that case, the diagnosis is less certain. The clouds of uncertainty, they dispersed 21 years later. In year 2022, Darius Coco came with this paper, sitting of vertigo as an expression of posterior semicircular canal heavy cupula and posterior semicircular canal short arm semicircular canalolithiasis. So this is an entity which was described much before in year 2011 by the Bela Buki. In 2011 paper, Buki found that in 20% of the classic BPPV, 43% had subjective vertigo, that is no nystagmus during the Hallpike position, that is the Dix-Hallpike position, and they termed this as type 2 BPPV or subjective BPPV. The symptoms classically arose when sitting from the one Dix-Hallpike position but not from the other side. That is the lead-like symptoms associated with persistent non-positional disequilibrium. They did a ad hoc posturography in many of these patients, and it showed posturographic truncal oscillations on sitting up in some patients. These three entities, the short-arm posterior semicircular canalolithiasis, posterior cupulolithiasis, and periampulary restricted canalolithiasis, are the putative mechanisms of the sitting up vertigo, which in the recent years have been found to have oculomotor patterns in many non-conventional positional tests. So this is a case 3 of typical right posterior semicircular canalolithiasis. A lady around 42-year-old, 7 days history of positively triggered disease spells. The right Dix-Hallpike test shows upbeating right nostril nystagmus. You can see. So I proceeded to do a apply maneuver hand in hand. Position 2 of the apply, I fast forwarded this. Position 3 of the apply, and the patient was uprighted then. Normally, I examine the patient 1 hour later and after 24 hours. At 24 hours, this patient came with the residual dizziness in the form of sitting up vertigo. I did a right Dix-Hallpike test, maintained the right Dix-Hallpike position for 1 minute, absolutely static eyes, no nystagmus. But because the patient was complaining of vertigo on sitting up from the lying down position, I did a evaluation of oculomotor patterns on sitting up from the right Dix-Hallpike position, and there I got this. Upbeating right torsional nystagmus on sitting up from the right Dix-Hallpike test. So when I got this, I did a right half Hallpike test. This was my first case when I started doing the half Hallpike, and so I used to use my hands to lift this up around 30 degrees. So this shows a prolonged duration nystagmus of more than 90 seconds. So after around 97 seconds, I did a inversion test, that is nose down to the left, to look for whether it is short arm posterior semicircular canalolithiasis of the right side. So this is the nose down to the left. The nystagmus disappears. Now there is a absolutely static eyes, no nystagmus, no oculomotor matters. Maintained for around a minute, and then patient was uprighted. So the important thing to learn from this case is that if patient complains of residual dizziness, as Dr. Surjit had said in his lucid talk, then look for the things which may be missing, and this was the clue which I got. Why inversion test is negative during the half Hallpike maneuver in the short arm posterior semicircular canalolithiasis? This is the sitting position. This is the right half Hallpike position. Because the otoconia in the short arm, they fall up on the utricular side of the posterior cupula, there is a stimulatory ampulofugal deflection. So there is a upbeating right torsional nystagmus of more than a minute duration, because in this position they will keep on deflecting the right posterior cupula ampulofugally. When the nose down to the right left is done, that is the inversion position, the otoconia fall away, and there is no cupular deflection, and the nystagmus disappears. So this is important whenever you do a half Hallpike test and you see a upbeating ipsitorsional nystagmus of more than a minute duration, you have to do a inversion test, that is the nose down to the opposite side, to differentiate between the short arm variant and the posterior cupulolithiasis. Unfortunately, in many of the patients, the two conditions, they often coexist. This is our fourth case, right posterior semicircular cupulolithiasis with positive inversion test. So this is a 61-year-old male patient who came with history of vertigo, positionally induced disease spells for 15 days. The right half Hallpike test showed first 2 beats of downbeating nystagmus, and then started the upbeating nystagmus. Very clear cut, very robust, upbeating right torsional nystagmus. It was of more than 2 minute duration. So I am making it fast forward. Then I did a inversion test. See the robustness of the nystagmus, and we'll see whether it remains as robust as in the half alpine position as it will be in the inversion position. This has a relevance which will be known to you as we proceed. So the inversion position, nose down to the left. The nystagmus reverses polarity. Now it is downbeating. It is left torsional, better seen in the right eye. The torsional component is better seen in the left eye. It again lasted for more than a minute. So this is a posterior cupulolithiasis, the of right side. The inversion nystagmus is almost as robust as it was seen in the right half alpine position, but the polarity of the nystagmus, both vertical as well as torsional component, has reversed. So this is a patient with right-sided posterior semicircular cupulolithiasis. So this is the summary of this patient. Case 5 is right posterior semicircular cupulolithiasis with weakly positive inversion test. This is an interesting patient which, in my opinion, had posterior semicircular cupulolithiasis as well as short-arm posterior semicircular canalolithiasis. A lady around 52-year-old, the right-sided half alpine test shows a upbeating right torsional nystagmus of more than a minute. Robust nystagmus, right torsional upbeating. Lasted for more than a minute. I am making it fast forward. And then I did a inversion test. That is the nose down to the left. The nystagmus reverses polarity, it becomes downbeating and left torsional. But you can see that in this patient, there is attenuation of the strength of the nystagmus. The directionality of this nystagmus has changed, both vertical as torsional component. It has downbeating and left torsional now. But the strength of the nystagmus is not as robust as it was seen in the right half alpine position. So when we reported a case of 9 series with of setting of vertigo, this is the right disc alpine test. Again showing upbeating torsional, right torsional nystagmus of more than 1 minute duration. Why we did disc alpine test? Because we wanted to know, we wanted to observe the oculomotor patterns on sitting up from the right disc alpine. So after 1 minute, she was uprighted, and there it is. You can see a upbeating nystagmus, which is right torsional. So this patient had a double pathology, that is the right posterior cupulolithiasis as well as right short arm posterior semicircular canalolithiasis. Many of you would be interested to know why did you make a double diagnosis. My reason will be clear in the next slide. Inversion test in heavy graviceptive posterior cupula, which I said, there can be 3 variations. One is that inversion test is strongly positive. That is, the intensity of the nystagmus in the half alpine position is as robust, and in the nose down to the opposite side, that is the inverse position. So this happens in when there is a posterior semicircular cupulolithiasis alone. The second is negative inversion test, as we had seen. In the inverse position, the otoconia fall away and there is no cupular deflection, and the inversion test is negative. While where the posterior semicircular cupulolithiasis and short arm posterior semicircular canalolithiasis coexist, a part of the posterior cupula is offloaded, and the nystagmus inverses, but its polarity is attenuated, that we saw in the last case. Our group has designated this as weakly positive inversion test to identify the two things which are co-occurring. So this is the case number 6. This is a very interesting case. The left short arm posterior semicircular canalolithiasis with upbeating ipsitorsional nystagmus on sitting up, negative Dix-Hallpike and half-Hallpike test. Is it a short arm semicircular canalolithiasis of the left side? This I would like to take the full video with the permission of the chair. 57-year-old male patient presented with 2 days history of vertigo on getting up from supine. His neurological examination was normal. The neurotological examination was as under the Dix-Hallpike on the left side, no position nystagmus. Oculomotor patterns on sitting up from the left Dix-Hallpike position, upbeating left dorsal nystagmus elicited. Left half-Hallpike test, the positional nystagmus, no positional nystagmus is elicited. This is the video. The left Dix-Hallpike, no positional nystagmus. I maintained this position for around a minute. And then he was uprighted. You can see a upbeating left torsional nystagmus on uprighting from the left Dix-Hallpike position. And this was pretty long nystagmus of around 70 seconds. So I wanted to know whether it is a short arm posterior semicircular canalolithiasis of the left side. So I did a half-Hallpike test also. Just in that case, I might see something. The left half-Hallpike test did not elicit any nystagmus. So I thought that it could be a variant of left short arm posterior semicircular canalolithiasis, where you get upbeating ipsitorsional nystagmus only on getting up from the Dix-Hallpike position. That is the lateralized Dix-Hallpike position as set by Scocco in 2019. So I had limited options of treating this patient. So the first option was the multiple sit-up from the lateralized Hallpike position, 10 in number. We maintain the Hallpike position for 5 seconds every time, and we do 10 sit-ups from the lateralized Dix-Hallpike position. And what Buki had advocated were 10 such sit-ups, 3 sessions per day for 7 days. That was the subjective BPPV where no nystagmus was found. That is the type 2 BPPV. So this was the day 1. I called this patient for a repeat Dix-Hallpike test the next day after doing this. Many of my patients, they vomit during the Hallpike testing, so that bucket always remain in my chamber and near my washroom. So next day, this patient came at follow-up 24 hours after physical treatment with multiple sit-ups from the left Dix-Hallpike position. The retesting was done as under. The left Dix-Hallpike test elicits a upbeating left torsional nystagmus in the head hanging position. This is here. Upbeating left torsional nystagmus of less than a minute. So this patient had transformed to the typical left posterior semicircular canal BPPV after multiple sit-ups, and this is practically not possible in short arm. So what happened in this case, that this was a case of This is a periampullary posterior semicircular canalolysis with partial canal jam. The free-floating otoconal debris in the descending portion of the periampullary posterior semicircular canal encounters an ampulofugal restriction, either a large clot like this. First, there is a negative inertia during the Dix Hallpike. The cupula doesn't deflect. On getting up, because of the gravitational force, there is a plunger effect and the posterior cupula deflects and there is an upbeating ipsitorsional nystagmus. So final diagnosis, periampullary left posterior semicircular canalolysis with partial canal jam in the periampullary region, either a large otoconal clot or a structurally narrow short segment of the posterior canal functioning like a low pass filter. This is a Scocco variant of 2019. So what did the initial forces did? Possibly multiple sit-ups from the left Dix-Hallpike position fragmented the otoconal clot, which was facing a jam, either a physiological or a anatomical. The clot fragmented and it paved way and it resulted in the typical posterior semicircular canalolithiasis. This I have already seen in the video. The first negative inertia, there is an ampulopetal movement of the debris. Then because of the gravity, it falls ampulofugally and causing a upbeating ipsitorsional nystagmus. That is the exactly what happened in this case. So the posterior semicircular canal short arm summed up here. The core features remains the same as by Bela Bucchi. Subjective BPPV sitting up vertigo, non-positional disequilibrium, no nystagmus on positional tests routinely carried out. Abnormal truncal oscillations during and after sitting up. In some of the cases, half Hallpike test shows upbeating ipsitorsional nystagmus of more than 60 seconds with negative inversion test. Some of them may have upbeating ipsitorsional nystagmus on getting up from the lateralized Dix-Hallpike position. Some of these patients may be associated with posterior semicircular cupulolithiasis, where we get upbeating ipsitorsional nystagmus for more than 60 seconds with positive inversion test. And some of them may have upbeating ipsitorsional nystagmus on getting up from the lateralized Dix-Hallpike position. Many of the patients whom we treat with typical posterior semicircular canal BPPV have residual dizziness, as we saw in one of those patients, and this can present with type 2 BPPV and now with the oculomotor patterns as described by Scocco in 2022. So that right Dix-Hallpike position, which is shown here, this is the short arm having the free floating otoconal clot shown in red here. As the patient is taken up to the sitting position or the half Hallpike position, the otoconia, they fall on the utricular side of the cupula, and this is a dynamic heavy cupula, which I was talking about the inversion test. The inversion test is negative and you get upbeating ipsitorsional nystagmus on getting up from the Dix-Hallpike test. And recently in one of the papers by Ji-Soo Kim, they have done an augmented half Hallpike test. The second situation is chronic low-grade cupular deflection. This is the type 2 BPPV. Short vertigo, retropulsion, anteroposterior truncal oscillations demonstrated by ad hoc posturography and non-positional disequilibrium. So this is what is happening there. The third is graviceptive heavy cupula due to cupulolithiasis, where the inversion test is positive as per Applet 2001. So the short-term treatment options are repetitive sit-ups from the Dix-Hallpike position 10 times per session for 3 sessions every day for a week. And this somehow worked on one of my patients, the last patient which I had shown, in periampullary restricted posterior semicircular canalolithiasis with partial canal jam. Bo and Yao maneuver in one of the studies from South China reported a efficacy of this maneuver in treating short-term posterior semicircular canalolithiasis. brand of exercises by Skoko and recently by JS Kim. Sitting up vertigo is therefore two types. Short arm with core features I have already mentioned. Some of them have a half alpine test with upbeating ipsy torsional nystagmus for more than 60 seconds with negative inversion test. Some of them have upbeating ipsy torsional nystagmus on getting up from the verticalized disc-alpine position. Some of them they are associated with posterior cupulolithiasis where you get upbeating ipsy torsional nystagmus for more than 60 seconds with positive inversion test. The second arm is periampulary restricted posterior semicircular canalolithiasis with partial canal jam. The last case which we saw, the core features remain same, but the important thing is that many of these patients they transform into typical posterior semicircular canalolithiasis either spontaneously or with some form of physical treatment. And again, remember that the typical posterior semicircular canalolithiasis, when treated with some form of repositioning maneuvers, may have residual dizziness, and this may be because of the short arm. This is my last case, concurrent posterior cupulolithiasis with canalolithiasis. It is important to know that the canalolithiasis of posterior semicircular canal has upbeating ipsy torsional nystagmus. Of cupulolithiasis, it lasts for more than 60 seconds. So if you have a concurrent posterior cupulolithiasis with posterior semicircular canalolithiasis, it is impossible to diagnose. Your observations are based on the inversion test, which is positive on the cupulolithiasis, and on the basis of the reversal nystagmus, which you get in posterior semicircular canalolithiasis in patients on getting up from the disc-alpine position. So this is a lady around 41-year-old patient, came with the history of positionally triggered spasms. Right disc-alpine test shows a upbeating right torsional nystagmus of more than a minute. I am fast forwarding this to around 1 minute to save time for discussion and panel discussion. Sitting up from the right disc-alpine shows a nystagmus which is downbeating and left torsional. So this is a paradox. In right cupulolithiasis, the inversion nystagmus does not occur. The type of nystagmus you get in posterior cupulolithiasis is same, which is you see in the half alpine or disc-alpine position, that is upbeating ipsy torsional more than 1 minute. And here you see a inversion nystagmus, where here you see a reversal nystagmus, which is downbeating and left torsional. So we did a straight head positioning in the supine position, which elicited upbeating nystagmus. Again, this lasted for a minute, right torsional. Then we did a half alpine position, upbeating right torsional nystagmus, very faint. It is not as robust as it was seen in the right disc-alpine test. And then we did a inversion test. The nystagmus becomes downbeating and left torsional. So there is no doubt that the posterior cupulolithiasis is present because of the positive inversion test. And in my opinion, the canalolithiasis is also present because the nystagmus, that is the reversal nystagmus, had opposite direction on getting up from supine. So why nystagmus reverses in posterior semicircular canalolithiasis? That you can see from this diagram. Initially, during the disc-alpine test, there is an ampulofugal stimulatory the movement of the otoconia, and on getting up from the disc-alpine, the clot moves towards the ampulla, that is the ampuloputal cupular deflection. So when the patient is upright, you would wonder that this is the position of the posterior cupula, and the heavy posterior cupula should have a ampulofugal cupular deflection. So these patients should have a spontaneous nystagmus, that is the patients with posterior cupoidal lithosis, even in the upright position. But there is a phenomenon of set point adaptation. What does this phenomenon do? There is no spontaneous nystagmus in the upright position in patients with posterior cupoidal lithosis, suggested a potential set point adaptation. A process of set point adaptation mitigates the nystagmus that could interfere with the visual stabilization. So when you make the patient rise up from the Dix Hallpike or half Hallpike position in posterior cupoidal lithosis, the set point adaptation is disrupted and you see the nystagmus which is upbeating and ipsitorsional. That is the type of nystagmus you elicited during the half Hallpike or Dix Hallpike testing in the posterior cupoidal lithosis also occurs on getting up from the Dix Hallpike or half Hallpike position. With that,